Good morning. So today we're going to talk about vancomycin and aminoglycosides in the adult patient. So this lecture is meant to be an overview of the medications, how we monitor them, and then we'll have a subsequent lecture specific to the pediatric patient. So the objectives for this presentation are that by the end you'll be able to review the mechanisms of actions of these agents, to discuss the pharmacokinetic and pharmacodynamic properties and empiric dosing regimens, to formulate plans for monitoring and adjusting regimens, and to review the pharmacist consult for adult patients. So let's start off by talking about vancomycin and its history. So vancomycin was first isolated from Aminoglycoside orientalis in 1952. So it's actually kind of an interesting story. Eli Lilly was looking for antibiotics that had increased spectrum of activity against agents that were penicillin resistant. So they a missionary in Borneo actually sent soil samples back to Eli Lilly, and they found vancomycin, and that was in 1952. By 1958, they had a medication that was ready to be used, and this was termed Mississippi mud, vancomycin. And that's because it had a lot of impurities when it was first made, and those impurities also, we think, is why we saw a lot more nephrotoxicity when the agent was first utilized. Because there was no other effective agents for these penicillin-resistant infections, vancomycin was quickly used throughout the U.S. and was almost immediately approved by the FDA because of the need. However, in that same year, methicillin was FDA approved, and cephalosporin was. And so those agents could also be used for penicillin-resistant infections and have less toxicity, less nephrotoxicity than vancomycin. So vancomycin actually wasn't used a whole lot when it first came out. In 1961, we first had reports of MRSA. So, as I said, in 1958, methicillin came out, so that was preferred, but now, 3 years later, we are starting to see some methicillin-resistant Staph aureus. In 1975, the prevalence of MRSA is still pretty low, 2%, so we're not seeing a whole lot of use for vancomycin yet. Really, the only patients that it was being reserved for were those with serious infections that had penicillin allergies and couldn't receive methicillin. By 1996, the MRSA rate was 35%. So really in the late 80s and early 90s is where we started to see a big surge of the use of vancomycin. And today, our MRSA rate is around 40 to 60% within the United States. And Orlando Health, and this is just from the antiviral this year, our corporate MRSA rate is 46%. So pretty high, and you can see why, and there's empiric use of vancomycin for a lot of infections. I do also want to say that in 1986 was the first case of vancomycin-resistant enterococcus reported. So then we start to see a need for even different agents. And in 1987 was the first case reported in the United States. So how does vancomycin work? Well, it works within the cell membrane. N-acetylmuramic acid and N-acetyl-glucuronic acid, so NAM and NAG, are these subunits that make up the cell membrane for the cell wall. However, in these, when vancomycin is utilized, it prevents that binding to the cell membrane of those subunits, and that's how vancomycin is effective. So you can see here, it prevents those subunits from binding to the cell membrane. So what different infections can we use vancomycin for? Well, generally it's going to be gram-positive infections, almost entirely, and mostly aerobic infections. So you can see there's a few anaerobic infections that vancomycin is effective for. And those common aerobes that we see vancomycin used for include staphylococcus and streptococcus. You can see the whole list here, though. In 2006, there was a change in the breakpoints from CLSI and what bacteria we can use vancomycin in, so a change in MICs. And this is because there's increasing reports of vancomycin failures at susceptible MIC values. There started to be vancomycin hetero-resistant populations were being described, and these were seen at an MIC of around 48. So within these populations of infection in a patient, you start to see some of the bacteria had vancomycin resistance. So then when you start to treat with vancomycin, you then have those that continue to populate. So around 4 to 8 is where those started to be seen. So there was a change in the breakpoints. So you can see up to 2005, susceptible was MIC of 4 or less, and then from 2006 on, it was changed to MIC of 2. And the MIC is the minimum inhibitory concentration. So this is a concentration of vancomycin or any drug in the blood that prevents the growth of that bacteria, so inhibits growth. And we start to see that, resistance at even lower concentrations of drug in the blood. But even though the lab is going to report an MIC of 2 or less as susceptible, we need to be careful if the MIC equals 2 when treating Staphylococcus aureus infections. And this is because inferior outcomes have been identified when the MIC is 2 and you're treating Staph aureus in particular. So for those cases, we want to recommend daptomycin or linezolid. This doesn't apply to other organisms though. So if you have a coagulase negative staph infection and the MIC is 2, that is still susceptible and it's appropriate to use. But you need to be careful if you have Staph aureus and you have an MIC of 2, because the lab can report as susceptible, but you have increasing inferior outcomes have been identified. So we want to recommend another agent. So let's talk a little bit more about the pharmacokinetics, pharmacodynamics of vancomycin. It's actually a little bit, we talk about most drugs being, or most antibiotics being ones that are time dependent or concentration dependent, but vancomycin is different, and that really it's most effective when you look at both of those together. And that's because the AUC over MIC is most predictive of efficacy. So, and the AUC over MIC value that's been identified as effective is greater than 400. And I'll show you a graph on the next page. So this is the concentration of drug in the serum. And so we can see when it was given, we have a spike and then it goes down. And so vancomycin is most effective when we're looking at the area under the curve. So how much drug you're seeing under that area, under that curve. And if we have an MIC of 1, anything above this line is going to be area under that curve. But if we look at an MIC of 2, for example, you can see how much smaller the area really is from here to there. So that's what we're looking at. We're looking at efficacy, the area under the curve. If you wanted to actually calculate this for a patient, it's possible. You would have to get frequent blood draws, and we could get levels at time 1, time 2, time 3, time 4, and draw this graph out, look at our MIC, and figure out what that number is. But that would require a lot of lab draws and a lot of calculation by us. So what we do monitor is troughs. And we've been able to identify which troughs correlate with what area under the curves. So that's kind of how we do monitoring of vancomycin based on its kinetics. Volume of distribution is also something we have to think about when we're talking about pharmacokinetics dynamics of the antibiotics. And the volume of distribution describes how a drug distributes throughout the body. We assume a 2-compartment model, and the 2 compartments are your serum, your blood, and all other tissues of the body. So 2 compartments. It goes from your blood to the rest of the body. You see it makes a little equilibrium between the serum and the tissues. Lipophilic drugs, which vancomycin is a lipophilic drug, have a large volume distribution because they're distributing throughout the fat, throughout the tissues in the body. So it has a bigger tank to fill when we talk about lipophilic medications. So obese patients are going to have a higher volume distribution, a larger volume to fill. Once that volume is filled, though, you might start to see accumulation of the drug, and then you might need lower maintenance doses. So this is if you see a patient that's on vancomycin for a few weeks, and you start to see an increase in their levels. It may not be because they're having renal dysfunction, but it might be because you've now kind of filled up that tank, and now you're seeing an increase with levels. And that's in particular in obese patients. So this graph here shows what it looks like when we use loading doses, because we do use loading doses for our adult patients. So our yellow line is a patient who received a vancomycin 3-gram load, and then our blue line is a patient who received just vancomycin 1 gram every 24 hours without a loading dose. And you can see that we're reaching troughs that are therapeutic faster than if we didn't give a loading dose at all. So in this case, if we were aiming for a trough of, let's say, like 15, we're not getting that until hour 72, versus the patient that got the loading dose, and we're closer to 15, within the first 24 hours. So how do you determine the appropriate initial dosing? Well, most institutions do have protocols to determine initial maintenance dose, and certainly we're no exception here. And the doses range from 10 milligrams per kilogram to 20 milligrams per kilogram, and the frequency is going to depend on the patient's age and their renal function. So patients that are young, have good renal function, are generally going to have dosing intervals of every 8 hours, while patients who are middle-aged have average renal function, they're generally going to have every 12-hour dosing, and those patients that have poor renal dysfunction or poor renal function are going to receive every 24-hour dosing or even pulse dosing vancomycin. The dosing for vancomycin is always going to be dosed on the actual body weight. So a loading dose is going to be recommended 20 milligrams per kilogram, unless the patient is critically ill, and that's going to be 25 to 30 milligrams per kilogram. The maintenance dose is going to be 15 milligrams per kilogram every 8 hours in our healthy patient that's young with good renal function, but then obviously going to Q12, Q24 as needed. Patients who are obese, who have a body weight greater than 140% of their ideal body weight, it's recommended per protocol that we give 10 milligrams per kilogram Q12. And we'll talk about how this applies to our patients at Winnie, our pregnant patients, because sometimes that's not a high enough dose and we still do Q8 dosing because those are healthy young patients that have a larger body weight because they're pregnant. So monitoring. We do want to monitor when the trough is at steady state. So this is going, our recommended goals are 10 to 15 for skin and skin structure infections, for urinary tract infections, and for catheter and line bloodstream associated infections. We're going to aim for a trough of 15 to 20 for bacteremia, endocarditis, pneumonia, osteomyelitis, meningitis, necrotizing infections, so more serious infections. And if a patient comes in with, say, a UTI, but then they worsen and now they have sepsis, they're in the ICU, certainly we want to move towards a trough of 15 to 20 in those patients. Patients who have renal dysfunction, who are specifically on CRRT or hemodialysis, are a little more difficult to manage. Fortunately, we don't have a ton of patients at Winnie who fall into this category, but we do on occasion have patients with renal dysfunction. For CRRT, we dose those patients as though they had a creatinine clearance of around 30 mLs per minute. And patients on hemodialysis, those patients we're going to pulse dose. It's actually recommended that you get pre-dialysis levels, and there's a few reasons why. And those patients were able to not cause any delays in therapy by getting the levels in the morning and knowing that we can give vancomycin at the end of dialysis. So while they still have their catheter open, we can give vancomycin. And we do have recommended levels in the guideline for when we do pre-dialysis levels. In general, they're 5 to 10 micrograms per milliliter higher than the goal troughs if we were doing them after dialysis. However, if you do have a patient that they order a trough after dialysis, we want to use the same goal troughs that we do for a patient who's not on dialysis. And as I mentioned, we don't. There's some drawbacks to getting levels after dialysis, and this graph kind of explains why. Here we have a concentration of vancomycin in the serum, so you can see we're steady. Because the patient's getting dialysis, we're not having any clearance. Almost none, so they're pretty steady here. During dialysis, we have clearance of vancomycin, so you can see the concentration goes down. But as I mentioned earlier, vancomycin is think about it as a two-compartment model. So when dialysis is working, we're removing the vancomycin from the serum, just from the blood. But some of it's still maintained in the rest of the tissues in the body. So we've removed all this from the blood, but then we have this distribution phase where the vancomycin that's in the tissues is now redistributing to the blood. So originally it's going to be a lot lower until you have the vancomycin move back into the blood. And so if you do get one after dialysis, it's recommended that you get one 2 hours later. Now this certainly, we'll talk about pediatrics specifically later, but this is even more common within because they love to get levels right after dialysis, but we have to think about that, and that our levels may look lower than they actually are. And so we may be dosing patients before we need to. So let's kind of just talk through a case for vancomycin for a woman patient. We have a 23-year-old female who's 60 kilograms and who's admitted for possible meningitis. So what should her initial loading dose be? You can just yell it out. What's it in mg per kg? 25 to 30. Yep. So how do you decide between those two? Well, I usually calculate both and look at what a normal kind of round dose would be between those two. So what would her dose be?
1,500 to 1,750.
Okay. Yep, so 1.5 to 1.75 grams. So either of those would be appropriate doses for this patient. So what should her maintenance dose be?
Should be
Sorry, I didn't warn you to have to calculate yours out.
20 mg per kg. 50 grams.
Yeah. So what is that? It's like 900 milligrams. So we could round up or down. She's closer to a gram and a serious infection. So I would probably consider doing a gram in this patient. And what would her frequency be? Well, it's going to depend. I did renal function, which I didn't give you yet. But let's say she has an estimated creatinine clearance of 100 mL per minute. What would you make her frequency?
QA.
Yeah. So in this case, maybe you do 750 milligrams Q8 because you did Q8. But if she has meningitis, maybe you do 1 gram Q8. So there's definitely some, you have ranges in there. So different pharmacists may come up with different regimens based on the protocol, and that's certainly okay. And you would want to look through her Sunrise, look through Sunrise and see other patient-specific factors which may help you dose her vancomycin. So now that we've started her therapy, when do we want to get a trough? Well, troughs are generally not needed if the planned duration is less than 5 days. So you may want to wait and see if she's going to have a positive culture. So if she has good renal function, they have a CSF culture, we're waiting for those to take 48 hours, well maybe we're not going to get a trough until we see if she's going to continue on therapy. If she does have a gram-positive infection and we're going to continue for therapy, then we'd want to get one after steady state is achieved. And steady state is achieved after about 5 half-lives. Before the 4th or 5th dose is a common time that vancomycin troughs are taken. The patient may not be at steady state. But that's kind of the most, and I'll show you in the next slide how we can more accurately determine what her steady state will be. We also want to monitor serum creatinine in our patients on vancomycin. Some other things that you may want to take into account when deciding on when to get levels for these patients are what time they're going to return. We don't want our patients to be stuck in the middle of the night if they don't have to. So if they're a stable patient, maybe we can wait till morning. And that's just a difference between the 5th and 6th dose. That's generally going to be okay. If cultures are about to return, hold off on getting those levels until we see if we're going to continue therapy. And then if the patient's receiving every 24-hour dosing, you may choose to get the level a little earlier, so before the 3rd dose instead of waiting to 4 or 5 days. So this is a steady state calculation that's also found in a guideline, and this is a way that you can determine when a patient may be at steady state. It takes a few things into account: the patient's creatinine clearance, their estimated volume and distribution, and then you're able to figure out after about 5 half-lives when their steady state may be. And this is particularly useful if you have a patient who has poor renal function or is obese, because they're going to take a longer time to reach steady state, so you can use this equation to figure out when that might occur. So talking about our patient, when would you want to get a level on her? Our patient with meningitis. Well, let's say we do the calculations. Maybe you want to do it before the 5th dose, but certainly you could do it before the 4th dose, or do the equation, figure out when the patient's going to be at steady state. And let's say we get a level of 13.7. What did you do for this patient?
Increase the dose.
Increase the dose. So why would you increase the dose?
You're not the target level.
Okay. Well, and what's our target level for this patient?
15 to 20.
Now, we could say that she's within 10%, so maybe we don't change the dose. But she has meningitis, so we have to worry about penetration, so maybe we would aim for a higher trough. So if you look just by the protocol, you may say, you know what, she's within 10%, we're good to go. But if you look at the patient, and maybe she wasn't improving, you have meningitis, that might be a patient you want to increase the dose on. And certainly other things we will want to look at for any trough: where did the patient receive the doses on time? When was her last dose? Certainly would be important. What time was her level drawn at? Is her renal function stable? So for this one, actually we'll talk a little bit for the next one too, but I would think that's a patient I would want to increase the dose on, or maybe have a discussion with that physician, especially if we knew it was a gram-positive infection and the patient wasn't improving. I would target a higher trough. Vancomycin does follow linear kinetics at the same frequency, so we'll kind of touch on how you make adjustments if it's not the same frequency. So what that means is you can do a simple ratio to determine your current level, your current dose, and what you'd want your new dose to be based on your desired level. So in this last case, we had a dose of 2.25, and we had a level of 13.7. So what would our desired level be? We could put 17, but I mean, there's a range, so. And in this case, our new dose, and that would be 2.75 grams. And we were dosing this patient Q8 already, so that would be 1 gram Q8. That's what we started with 750, and this patient.
Oh, it's the total.
Yeah, so this one is
the total.
Exactly, yeah. The
Okay.
2.25 is the total, but you can do it per dose too, since it's
Oh,
the
okay,
ratio.
Okay,
Yeah.
all right. I got it now.
So this, now that we know what the dose is that we want, we can also we can figure out what our level will be. Because we might make a small adjustment based on, rounding to an appropriate or easier to measure, easier to draw up dose. So in this case, we did 1 gram Q8, so that would give us a desired or predicted level about 18.3 micrograms per ml. Now something that comes up probably even more so in pediatrics if we start Q8 going to Q6, how does that affect our levels? And in the last equation, we just did a total daily dose, and so you might think, well, I can just divide it and the levels will be the same, but it's a little bit different than that. And this also sometimes comes up if someone wants to change adult patients from Q12 to Q8, or if you want to go the other way, the patient might be going home and you want to change to Q12, so it'd be easier for that patient to get those doses as an outpatient. So this shows the different concentrations based on the same total daily dose, but using different intervals. So the blue line here is if we gave 3 grams continuously over 24 hours. The red line is if we gave 1 gram every 8 hours. And then the yellow line is if we gave 1.5 grams every 12 hours. So these would be predicted concentrations. So we can see that 3 grams, we have the same concentration throughout the day. And then our 1 gram Q8, we have our troughs and our peaks. And then our yellow, which is the same total daily dose as our red, we have slightly higher peaks in some cases. We also have significantly lower troughs, and that's because there's a longer interval. So even though we're doing bigger doses, they're still going to go to lower troughs than if we're doing every 8-hour dosing. So this is important to keep in mind because if we make a change from Q8 to Q12, still keeping the same total daily, we're going to have a change in our troughs based on just the interval. Does that make sense? Okay. So again, to kind of summarize that, linear kinetics applies when we're using the same frequency. When you use the same total daily dose, but you give higher doses less frequently, you will have lower troughs. And so if you lengthen the frequency, you will have to give a higher daily dose to achieve the same trough. So 1 grams Q8 gives you a trough of 18.2, but 1.5 grams Q12 is going to give you a lower trough. So what are some of the long-term monitoring that needs to be done for patients on vancomycin? In our protocol, we recommended serum creatinine every 2 to 4 days, and vancomycin levels every 5 to 7 days if patients are going to continue on it and are stable. If a patient has a change in renal function, is prescribed other nephrotoxic medications, we may consider earlier troughs. So let's talk about some specific pearls for the patient at Winnie Palmer. Well, pregnant patients are often going to be over 140% of their ideal body weight. So the protocol says to dose them 10 milligrams per kilogram IV Q12 hours. But as I touched on earlier, we often see that gives levels that are too low for young patients that are pregnant. So you may choose to do 10 milligrams per kilogram IV Q8. So this is slightly different than our protocol, but it's going to require you looking at that patient, seeing what their urine output's like, what their serum creatinine is at, how old they are, and to try to get an idea of what might be the best dose for these patients. And also patients who are receiving vancomycin for group B streptococcus prophylaxis and or premature rupture of the membranes, or PROM, are excluded from the automatic consultation. The reason for that is that they're generally dosed 1 gram IV Q12 hours, and that's from the CDC GBS guidelines for 7 days. So they're getting really small doses generally for their size, and we would expect the levels to be pretty low. So we're not going to be consulted on those patients because we're not going to be following levels generally. But sometimes they do require levels if they're going to be, for example, if they have a very low body weight or if they have renal dysfunction, it would be ideal to get levels in these patients just to make sure that their levels aren't too high. We're not trying to achieve any target, so there's not 10 to 15, there's no target trough. We want to make sure that we're not going super therapeutic in these patients. Are there any questions on vancomycin?
Is that the loading dose or maintenance dose that you mentioned? The 10 per kg?
there?
Oh, that's a great question. So, the question was, talking about 10 mg per kg Q12 for obese patients, was that the maintenance or the loading dose? So that was the maintenance dose. And the loading dose is really just to kind of fill that tank. So we're gonna do the same loading dose in every patient regardless of their weight or their renal function. So everyone gets the same loading doses, but then the interval, the maintenance dose is gonna change based on their renal function and whether they're obese. Thank you, that's a good question.
PD, peritoneal dialysis. What's the dosing for that in terms of how we approach that when it goes in?
That's a good question. So the question was about peritoneal dialysis and how we dose those patients. So that is, those patients, you mean like intravenously versus in the
Yes.
intraperitoneal fluid?
Yes, yes. Oh, yeah, because I know we don't put the vancomycin in the fluid here, correct? They do it separate, or we do both?
We do both. And
Okay.
actually,
Okay, because I've seen it both ways, so I'm not sure what we do
yes,
here.
that's a great
We see it
question.
IV a lot more, that's for sure.
Oh, okay. I'm like, maybe they do it here too. I don't know, but
Yeah.
okay.
Well, tomorrow, there's going to be new peritoneal dialysis
Okay.
antibiotic guidelines that are coming out for pediatric and adult patients that will give, that will tell you how to dose patients who are on peritoneal dialysis. Specifically for the fluid, how to dose them, what concentration to use, what dose to use. And so that is explained in great detail for all of those patients. But for peritoneal dialysis patients, they're probably going to be pulse dosing to start off with. And then if you see that you're able to give consistent intervals, so you're giving it every 3 days, then maybe you could schedule it, but generally they're going to be pulse doses for those patients.
They're still getting a load as everybody else, and then they're going to do, based on
Yes.
your weight, 10 milligrams or whatever, 15. Okay.
Yep. And then get a level, in a few days, see what it is.
Question again, I'm sorry.
Just peritoneal dialysis, like, how we go ahead and dose those patients when they do come in, because I've seen it before, so
Yeah.
I wasn't sure.
Your
like,
question was, though, you said something about, do we do?
well, if is the vancomycin put into the
In the
peritoneal in the
bank-
bag,
okay, that's
or
what I
are we
thought
doing
you
it outside of
I
the
just
bag?
wanna make sure I-
And if it does matter how we dose, if it's in versus out, if we're just giving it IV, just a thought. I don't
The
know.
aminoglycosides in the bag at times. Well,
Mhm.
So I just wasn't sure.
Yeah. Yep.
It depends.
Sure.
Yeah.
Yeah. As there's a new guideline that's going to come out. We're going to talk about it tomorrow.
That's awesome.
Yeah, that has the dosing for pediatric and adult patients for all the antibiotics and the peritoneal dialysis solutions. But then if you're giving it IV, it would be pulse dosing. Do you want to know?
I'm good.
Okay. Any other questions for vancomycin? Okay, so let's talk about aminoglycosides. So some fun history of aminoglycosides. Streptomycin, amikacin, and tobramycin were first isolated from Streptomyces species in the 1940s, and gentamicin was isolated from Micromonospora species. So the mechanism of action, they inhibit the 30S ribosomal subunit, so they're going to inhibit protein synthesis within the bacteria, specifically within the 16S portion. And within bacteria, prokaryotes, there's the 1408 position is adenosine. And this adenosine kind of forms an internal bulge that allows access to the ribosomal binding unit for aminoglycosides. And this actually has some resistance that's conferred to aminoglycoside. If there's a change in that adenosine, then that bulge may be gone and the aminoglycoside may not be able to penetrate into the 30S subunit. How it's specifically bactericidal is unknown, but there's many theories on how that occurs. One, it might be due to trapping of the high concentration of drug within the bacterial cell, inhibition of DNA replication, RNA mistranslation, and cell membrane dysfunction. So as I mentioned, it's inhibiting the protein synthesis, but which of that inhibition relates to the bactericidal activities is unknown. So what can we use our aminoglycosides in? Well, it's going to be aerobic coverage only. So it doesn't cover any anaerobic infections. It's going to cover gram-negative mostly, so our Enterobacteriaceae. So this includes things like Klebsiella, E. coli, our space bugs, so Pseudomonas, Acinetobacter, Citrobacter, Serratia, Enterobacter. There's some gram-positive coverage, but that's synergy only. And the reason for that is that gram-positive agents have a cell wall that aminoglycosides can't penetrate. So if you were to use an aminoglycoside alone for an Enterococcus or a Staph aureus infection, it's not going to be efficacious at all. But if you use it in combination with a cell wall active agent, so like a beta-lactam, then it's able to get into the cell and then have an effect on that protein synthesis from the bacteria. So kind of an easy way to think of it, and what I tell the medical residents, is you need a cell wall active agent to punch a hole into your bacteria, and that allows your aminoglycoside to get in and have an effect. There are some other infections that covers, tuberculosis, mycobacteria infections, a few other random ones that aminoglycosides cover. So some pearls to remember with aminoglycosides is they have poor CNS penetration, so they're not recommended for CNS infections. And I know we're going to do more about pediatrics later, but I do want to mention this is part of the reason why in neonates for rule out sepsis you may see ampicillin and aminoglycoside used, but if they are suspecting meningitis, they really should be switching to cefotaxime instead of an aminoglycoside because it has poor CNS penetration. Combination therapy is going to be used in almost every case, and that's because there's rapid development of resistance when you use it as monotherapy. The one exception is when you're using it for isolated urinary tract infections. And the reason why this is an exception is the aminoglycosides get very high concentrations in the urine, so they're still able to eradicate the bacteria if used just for UTIs. For gram-positives, as mentioned earlier, synergy only, so never alone. Now let's talk about some of the PK/PD properties for aminoglycosides. The aminoglycosides are all going to be concentration dependent, so we're looking at how high the Cmax is over our minimum inhibitory concentration. And we have some graphs for this as well. The intracellular concentration of the drug predicts its bacterial cytal activity. However, the extracellular concentration, so the concentration that you'd measure in the serum, directly correlates to that intracellular concentration. So we can use that, our serum levels, to determine efficacy. And also interesting with the aminoglycosides is they have a post-antibiotic effect. So what that means is there's persistent suppression of growth after your antimicrobial exposure. So the higher the peak, actually the longer the post-antibiotic effect is. And this is part of the reason that the once daily or extended interval dosing of aminoglycosides probably works so well, is because you still have this effect even after the concentration is lower. You can see we're looking at how high our MIC is over our minimum inhibitory concentration. Max. And there is synergism with other drugs that we've kind of touched on, the cell wall active agents, and it's actually synergy for gram-positive and gram-negative bacteria. The only exception to this synergy is with tetracyclines, and they actually have an antagonistic effect, and that's likely because they both work on the 30S subunit, so they're trying to get to the same place, and it actually, those patients do worse if on the combination of aminoglycoside and tetracycline. Unlike vancomycin, aminoglycosides are hydrophilic, so more of the drug stays within the serum, and less of it moves into the tissues, into the fat. And this is certainly going to, the volume of distribution is going to depend on the patient's age, their albumin, their fluid status, and in particular, when we talk about pregnant patients, they have a very large volume of distribution, particularly in the third trimester, and that's going to change their volume of distributions. We do use an adjusted body weight to dose aminoglycosides because it's a hydrophilic medication. And we do this if the patient's their actual body weight is greater than 120% of their ideal body weight. So how do they calculate that? And I know this is probably a pretty basic review, but just to be complete, for males, we're going to do 50 plus 2.3 times their inches over 60, and then females 45.5 plus 2.3 times their inches over 60. So if we have a 5'10" male who weighs 85 kilograms, what is his ideal body weight? Yeah, let's look. 73. Yep. Because we would do 10 times 2.3, 23 plus 50 is 73. It's not always quite so easy. So in this patient, do we need to dose based on his adjusted body weight, or can we use his actual body weight? It's okay. People watching the video, they'll have time to calculate this too, so. So we don't need to use his adjusted body weight because it's less than 120%. It's like 116. Yep, 116%. So we can use this actual body weight. So take home point, obese patients not dosed on actual body weight. So we have two different ways we can dose aminoglycosides, traditional dosing, and this is small doses, generally every 8 hours. And the reason that this aminoglycosides were originally dosed this way is there was a thought that high concentrations correlated to increased toxicity. However, later studies showed that extended interval dosing had some advantages. One, because the higher peaks relate to higher efficacy, and lower troughs relate to lower toxicity. There are some disadvantages. One, it's not studied in all patients. For example, there's very little pediatric studies showing how to manage these patients. Patients with end-stage renal disease, they don't clear adequately, so there's toxicity risk associated with using these high doses. And actually, we talk about a theoretical increase with efficacy, but that hasn't been shown in clinical studies. It hasn't been shown less efficacious, it just hasn't been shown more efficacious. What we have seen in studies is there is a decreased toxicity risk when using the extended interval dosing. So what patients should we not be using extended interval in? If they're 70 years or greater, if their creatinine clearance is less than 40, if they're on dialysis, if they're pediatric, so we'll talk about that at length later, if they're cystic fibrosis. And the reason these patients are excluded is because we're worried that they're not getting high enough peaks using this dosing. So we have modified dosing recommendations for them. Burn patients have very large volumes of distribution. Also patients who are very edematous, large volumes of distribution. Uncomplicated UTIs, because we don't need doses this high. And then pregnancy, so we'll talk about that as well. And then gram-positive synergy, because we don't need doses that high. So traditional dosing, there are calculations found in the protocol, and we're going to figure out the dose depending on the patient's your desired Cmax for the patient, their volume distribution, and their renal function. So we won't go through all the calculations, but they're all found within the guideline. But an important thing to remember when coming up with your traditional dose is to use what your desired Cmax is. So looking, you have pneumonia. Well, then your goal peak is going to be 8 to 10, and then using that for calculations to determine the best dose. However, often this is not done, and there's kind of standard mg per kg doses used for traditional dosing. And that's the same for our pregnant patients. In these patients, gentamicin is generally the drug of choice, unless we have a shortage, which we have in the past, and we have used tobermicin. All the aminoglycosides are pregnancy category D, and that's for the whole drug class. And that was based on issues in neonates, hearing issues, specifically with streptomycin and kanamycin. However, we have lots of experience, certainly even here at Winnie, that we aren't seeing those issues with gentamicin and tobermicin. So there's a lot of evidence that these are safe agents to use in pregnancy. And the dose that we use for these patients is 2 milligrams per kilogram load, followed by 1.5 milligrams per kilogram every 8 hours. Now in the guideline it says that we use this on actual, but you may also see it used on adjusted body weight because there's evidence to support both of those. But I think that often they're just ordered by actual because that's a lot easier for their physician to calculate or nurse to put in. 5 milligrams per kilogram IV Q24 hours has actually been studied in pregnancy at Winnie Palmer. They did a small study here, and they found that was efficacious. You probably won't see that frequently, but you may see it. They may see it preoperatively or for pyelonephritis, so that they can give the mom this once daily dosing instead of frequent dosing. Those were probably patients who have allergies to other beta-lactam agents, and this is something that's required. So how do we monitor traditional doses? We want to get a serum peak and trough around the 4th dose. The peak concentration is going to be 30 minutes after the end of the infusion. So if the dose is due at 3 p.m. and it's given over half an hour, that's till 3:30, so we're getting the level at 4 p.m. And their trough concentrations are going to be immediately before our next dose. Just for convenience, we often time them for half an hour before the next dose so that there's a better chance the nurse is going to see that before trying to get that trough at the same time she's giving the next dose. For uncomplicated UTIs and for synergy, we generally are only going to get trough values because even low doses are efficacious in these infections, so we just want to make sure that we're not, the patients aren't going to have any toxicity with the agents. If the levels are high, then in those cases we want to get a second level to look at clearance and make adjustments to the regimen. At steady state, we want to get peak and troughs around every 5 to 7 days, if the patient's going to continue on therapy. And then daily, we're going to look at urine output and get a serum creatinine about every 2 days is what is recommended in the guideline. So here again is our goal peaks and our troughs. So for gentamicin and tobramycin, our goal trough is 1 or less. And then for amikacin, we have 5 or less. And for gram-positive synergy, gentamicin is really what's been studied, so that should be the only agent used for gram-positive synergy. So let's also touch on hemodialysis and chronic kidney disease for aminoglycosides. In these patients, it's recommended to do a 2 milligram per kilogram loading dose. And then the subsequent doses are dependent on the kind of infection. So for UTI or synergy dosing, it's going to be 1 mg per kg after hemodialysis, so looking at patient's level. And then for other infections, 1.5 mg per kg after dialysis. And we have about 50% removed of aminoglycosides with dialysis. So in those cases, we're looking for that level to be less than 2 instead of less than 1. For amikacin, it's going to be the same sort of thing. The doses are going to be higher. For uncomplicated UTI, 7.5 mg per kg, then 5 mg per kg. And then for all other infections, a 10 mg per kg loading dose, followed by 7.5 mg per kg after hemodialysis per levels. And we redose for amikacin when the level is less than 8.
Susan, do we have to wait a period of time after the dialysis as well, like we did with the,
Sure,
with the
yeah.
tank of the 2 hours?
Well, in these cases, it's still recommended that you get a pre-hemodialysis level. So these levels here are double what they are post-dialysis. So we generally want a trough less than 1. So we're going to accept a trough less than 2, assuming that 50% would be cleared during dialysis. So yes,
These are
recommended.
pre-dialysis.
Yes,
Okay.
exactly. Yep. The 2 and the 8 are going to be a pre-dialysis. If you did get a post-dialysis, it wouldn't be as bad with vancomycin because it's more hydrophilic, so you don't have as much in the tissues. But you would still have a distribution phase because not all of it's going to be in the serum. So it would still be preferred that you waited, probably 2 hours period of time after dialysis to get the level. But still, preferentially, we want to get a level pre-dialysis. And it's probably easier if you're the one ordering levels to do pre-dialysis, because if you know that they get their dialysis on Monday, Wednesday, Fridays, you can get that level in the morning and not trying to figure out how to time it, right after dialysis. So let's move to extended interval dosing. For tobramycin, gentamicin, it's going to be 7.5 mg per kg based on our dosing weight, and then amikacin, 15 mg per kg based on our dosing weight. And then our interval is going to be based on creatinine clearance, so greater than 60 once daily, 40 to 59 every 36 hours, and then if they have a creatinine clearance less than 40, we're going to use conventional dosing. Monitoring is pretty easy compared to aminoglycosides that are conventional dosing. So we're going to get a random level 8 to 12 hours after the dose, and then plotted on our nomogram. So we got a level 8 hours after the dose. We would look to see where our level was. If it was 5, for example, every 8 hours, we would know that we're in the every 24 hours, so we can continue. If we were up here, it'd be every 36, and then if it was all the way up here, we would do conventional dosing. So you just gotta plot it on here, and then that lets you know how to continue therapy. And generally, we want to get trough levels every 5 to 7 days after that. So after we get that one random, we're good to go. If we're going to continue therapy, then you can just get trough levels about every week. And then there's recommendations here. For tobramycin, gentamicin, less than 1, we continue. If it's greater than 1, then we need to make adjustments. And then with amikacin, our goal is for less than 4. Now you may get sooner troughs than every 5 to 7 days if patients have any kind of change in renal function or they're on concomitant nephrotoxic medications. So what are some pearls for our Winnie Palmer patients? Well, levels are generally not needed with the first dose when we're treating chorioamnionitis or endometritis in postpartum patients. That's because they're only going to continue therapy 24 to 48 hours after the patient's last fever, so it's not worth getting levels in those patients. If they're going to continue for 3 or greater days, so if you see that they have positive culture or they continue to be febrile, then we do want to get levels in these patients. So let's kind of talk through a case for a Winnie patient. So we have a 33-year-old female who's 5'2" and 80 kilograms, who has chorioamnionitis and an estimated creatinine clearance of 90 mL per minute. The patient received gentamicin 160 milligrams IV × 1 followed by 2 doses of 120 milligrams IV every 8 hours. Is this a reasonable dose?
Yes.
Yeah, okay. So what's our mg per kg for our loading dose?
2.
And then for 120, 1.5.
1.5.
Yeah, these are reasonable doses. Now that the patient has delivered, what would your recommendations be to this dosing regimen?
Right. 224.
24, yep.
24.
So what weight to use? Well, in this case, she was 80 kilograms. So I'll tell you her ideal body weight is 50.1. So do we need to use an adjusted body weight? Yeah.
Is that pre-pregnancy?
And yeah, that's a great question. So we use their pregnancy weights.
Okay.
One, it'd be very difficult probably in a lot of our cases to find a pre-pregnancy weight. So yeah, we use their pregnancy weight. So most patients are gonna be over the 140%. So in this case, 160%. And so her dosing weight would be 62 kilograms. And so what would be the dose?
430.
Excellent. 430 milligrams every 24 hours. And when would you start the new dose?
8 hours after the last dose.
Yeah, so 8 hours after the last dose, because the patient was in conventional dosing every 8 hours, so they would be due for the next dose in 8 hours, so that's when we start the once daily dosing. And when would a level be needed?
That depends.
Yes. Excellent. Only if you're going to continue for 72 hours or greater.
Yeah.
So this is pretty typical for our winning patients that deliver, have a fever. Their management is a little bit easier than, let's say, a pediatric patient, because it's pretty standard, the dosing for these patients and how we monitor them.
So for a long time prior to this, they might not remember this, but we used to subtract 10 pounds from that weight
Oh,
and then go from there.
yeah.
So that was a good question. We used to do that, and that was to somewhat adjust for the fluid loss that they had.
Mhm.
But then somewhere along the line, we quit doing that, and I was never told why we quit doing it. So I just thought it was interesting.
Yeah,
But-
and they're really, and I've talked with Susanna about this before, and there's very little data about how to dose it in these pregnant
Yeah.
patients. And they deliver, so they've had a baby, they've clearly lost weight, but we're not getting new weights on them
Right.
right after delivery. So if we had a new weight, there certainly would be rationale, and 10 pounds, they've certainly lost at least 10 pounds.
They said that was mostly, like, even just in
Fluid, yeah.
fluid alone.
Sure.
It makes sense, right?
Mhm.
But then we quit, the protocol used to tell us to do that. Jen, remember? And then somewhere we just quit, right? But then I just never knew why. I thought it was interesting, though.
Yeah, no, that's a great point.
And not that it makes, I mean, sometimes
The
they only
doses
get
probably
one
be-
dose or 2 doses
Yeah.
and they're gone, so, and they go so quick.
Yeah.
Quick question.
Yeah.
So when you're using adjusted body weight,
Mhm.
are you looking for their actual body weight to be 120% over ideal or 140? Or is it different for the 2 drugs?
104, yes, different for the 2 drugs.
Okay, so for aminoglycosides, it's
104.
120.
120, thank you.
120, because I think you just said 140.
Oh,
Yeah, 140 was
140 is
Vanco.
fine.
Okay, that's.
Thank you.
I just
Hopefully
checked
it's
it.
different. No, for possible getting.
That's what I thought, but I
As the
just heard you
protocol.
say 140, and I thought, oh, maybe I'm,
No, no.
all right.
Yes, yeah, thank you. So it's 100, yeah, they're different. Yep, and with vancomycin, we don't come up with an adjusted body weight, we just
Right.
determine obese, no, go.
Yeah.
Yep, 120. So what are some keys to success for managing these patients for aminoglycosides or vancomycin? One, it's not going to be as useful for patients that are just here and delivery, have fever afterwards, but we do want to look through past regimens. If they're on vancomycin in the past, what dose were they started? What were their levels? How has their renal function changed since then? And that gives you a lot of information about how you should restart the regimen now. We want to look for changes in renal function. Because even if we don't plan on getting a trough for, let's say, 7 days, and we identify that their serum creatinine is going up, the urine output's not looking as good, we can go ahead and proactively get a level earlier. Or in some cases, the renal function is severe enough, even holding the drug and getting a level right away. We want to write consult notes when initiating, evaluating levels, even if you don't have a change in therapy or changing the dose. You want to contact the physician if you see cultures that indicate a change in therapy is needed. So if you're on vancomycin, you're on day 2 of therapy, your cultures just came back and they have pseudomonas, well, go ahead and call that physician and make sure that they're aware of those cultures, particularly before you go to level, but also to be able to make recommendations for more appropriate antibiotics. And we want to make sure we're communicating plans to those following you through the SBAR and excellent consult and progress notes so that the pharmacist following you can know what your plan was and what your kind of why you did what you did so that they can follow you appropriately. So in summary, vancomycin acts on the cell wall of gram-positive organisms. The PK/PD parameter is AUC over MIC. The initial dosing is based on weight and the renal function. The steady state is achieved around the 5th dose most often, but we can calculate when they'll be at steady state, and we monitor trough values. It follows linear kinetics. And then aminoglycosides act on the 30S ribosome. They work on gram-negative and synergistically for gram-positive organisms. The PK/PD parameter is Cmax over MIC, and it exhibits that post-antibiotic effect. And the extended interval dosing is preferred regimen in most patients due to lower toxicity and a theoretical benefit for efficacy. And one-time levels 8 to 12 hours after the infusion are used to monitor. Traditional dosing is used in special populations, and then in those cases we monitor peak and trough. So are there any other questions?
I'll try to ask without shivering. So the differences between like obese patients and pregnant women patients. So you mentioned that Vanco is a lipophilic drug,
Yes.
so it has a large volume distribution. So in obese patients, it's slower to reach steady state.
Sure. Yes.
So in pregnant women, what's the difference between obese and pregnant patients?
So in regards to like reaching steady state,
Right.
well, that's a complicated question.
And if you can comment on aminoglycoside, because that's not a lipophilic, that's hydrophilic drug.
Yes. So in pregnant patients, they're going to have a larger volume and distribution, particularly throughout pregnancy. So it's going to be even higher in their 3rd trimester. So in those patients, it's likely more fluid. Part of it is, but even when we're using the aminoglycoside, the calculation to determine steady state, that's really meant that those weights are meant for obese patients who aren't pregnant. So whether that applies perfectly to pregnancy, we don't know either. There hasn't been many studies on pregnant patients and monitoring of our antibiotics. So I don't know that I can speak to how we would use that equation.
Pregnant women in general,
Mhm.
they have an increase in, I would assume, fat, right? Or no?
Fat and fluid. There's no fat. I don't know what you're talking about. It's babies.
There would be a lot of fluid, you hope.
It'd probably be more fluid, but there would be an increase in,
Yeah, the
certainly
goal
an
is to
increase in
just have
fat.
fluid.
Back to your
Like when
pre-pregnancy
you
weight.
said you wanted to know, is that our pre-pregnancy weight? I said, oh my gosh, if you told them all that, you'd have to hand them all Prozac too while you're asking them that question.
Iron dextrin, iron sucrose, and Susanna.
Yeah.
And then the iron dextrin order protocol, they used pre-pregnancy. And then for sucrose, they have just ideal body weight. So I was just wondering, how do you even know what the pre-pregnancy weight is?
It's verbal. It's not documented anywhere.
So that's
Maybe
what
not. And it's maybe 1, maybe 2, maybe 3, I don't know.
And everything given the fact that all women lie about their weights.
I did, they asked me for what's your weight. Oh, you're the scale.
Yeah. Don't anybody over here look at that bigger line. No, I'm just kidding.
Okay.
I'm sorry, yeah, I don't have a very good answer because there's very little data when looking at like the volume distribution. Because you're right, those calculations is probably not quite right looking at their weight because it's a pregnant patient. There's more fluid than there would be someone at that same weight that wasn't pregnant. But we found the levels still correlate well enough that we're able to use these same dosing regimens for them.
Do you wonder too, because in those iron dextrin ones where they use the pre-pregnancy weight, a lot of times we're not dosing that later in pregnancy. Oftentimes those are like really early pregnancy.
Early pregnancy.
So that might have something to do with it. And that's just my observation over the course of me being here. They're usually really early in pregnancy.
That's true, good
Okay.
point.
My other question was extender interval dosing. Why is that contraindicated? Or we can't use that in pregnant or special populations?
In pregnancy.
in
right?
pregnancy specifically.
Mhm.
Yeah.
Yep.
The reason is there are concerns that if you're doing extended interval, you're doing big doses, and that it may lead to hearing impairment in the neonate.
Okay.
So that's kind of theoretically why. And the neonate, yep, not in the mom. So that's why it wasn't used. And then with streptomycin, kanamycin, they actually did see cases of hearing impairment in the neonate. So that's why there is that the higher doses aren't being used. But 5 milligrams per kilogram, there has been some studies in pregnant patients, and those were looked okay. But in general, we don't use a higher dose in pregnancy.
They actually confirm their delivery as well, usually. We'll confirm that they
They
did.
did.
Isn't it funny, they did the studies with the kanamycin and the streptomycin, when's the last time you just missed one of those?
Yeah.
It's kind of, isn't that interesting? I mean, I just thought I'd throw that
The
out.
studies are fairly old, I would take.
Yes, and I don't even know if there were studies more so than
I don't think
they
there was
used the
any.
drug and found that there was hearing loss in the
Yeah.
infant versus like a study looking
But
at
you
it.
would wonder it probably would
Maybe.
correlate with them too. I mean, they're the same family. So interesting. I didn't realize the
And
studies.
then my last question is, sorry,
I never
it's a lot of
read
questions.
That's okay.
No, please.
For patients with VRE, linezolid and Adapto, that's formulary here?
Yes, both linezolid and daptomycin have restrictions, so they have to be approved by the antimicrobial management team for Winnie or by a PEDS ID physician at APH.
Okay. Thank you.
Yeah.